scenarios, because that's what I'm going to do to you. Where does it say that? How did you get there? How did you get to this patient has COPD? Off of chest wall secretions. Can't do that, right? Secretions were present in the right. Nothing in there says anything about right. See, you can't make assumptions, right? But I can say they were there and they're gone. That's what I hold on to. Patient has chronic. Well, again, can I say chronic? You see how your test-taking skills need to come into play? Right away, I'm eliminating, I don't even need to look at any of that. I can just read my answers and know COPD, COPD. It's the same answer. So why did you pick this one over this one? For the person that picked that. I'm just saying. Do you see how you have to approach these? They're going to make them clear cut, guys. When they give you a PFT, they're going to give you 3 restrictives and 1 obstructive. What do you think the answer is going to be? Just by looking at answers. Dude, don't let it play you. I know a big test. Take your time. Look at it. Put in the work. Right? I'm telling you. COPD, COPD. Can't do that. Can't do it. Right? Didn't say anything about the right, so we can't make it up. Don't do that. Okay? And I'm going to see, probably a lot of you are going to walk after a few of these because you'll be like, dude, what? Come on, really? That's how it is. I'm telling you, over and over, they're really simple. Again, this was just recall, guys. What is that?
Group.
Listen, look what it says. It falls in all levels. All levels, guys. And 16% still believe that's epiglottitis. But that's a difference of your TMC score of scoring 91 to 92. And it happens more than you would like to know. One question can make a difference if you move forward. One question, guys. 3 hours of your life and money now you've got to come out of your pocket for the next exam. It's crazy. I can't express how I don't want that to happen to you. And this is how it will happen because of recall and placements. We'll get better. This is the first one. But understand, 16%, that's a little concerning on a clear-cut recall question. Didn't recall. That means this was a study question, right? Just think about that. All right? All right. So going over here. Now, look at this. I see where everybody was on the same logic. You definitely had to remove 2. But why would you remove 1 or 3 and maybe 4? Well, if you picked 1 and 3, you guys know these are bacteria. We're not looking for gram positives or negatives right now. What does it ask? What organisms are destroyed by disinfectant agents? Everything but spores. Those are the same, guys. Those are the same. And they say negative and positive, but at this level, I don't care if it's negative or positive. It's a bacteria. Right? That's all they're asking. What does it kill? Bacteria, viruses, or spores. That's all we're looking at. Is there anything else we were trying to look at? Bacteria, viruses, spores. That's how you categorize all of this. Sterilization. Go home. What falls in that? I just told you the 3 you need to look at. Then you can go into steam autoclave, all these other things, right? But really get to the what? What is disinfectant? What's the category? What does it kill? Sterilization. What does it kill? Associated, you see what I'm saying? Sporocidal, it's there. What does it kill? Okay. Alright, so 63-year-old male patient, that's what we got right here, So look, anytime, guys, and Brown, okay, this was blown back into the circuit. So you're looking, coughs up blood and secretions. So, flush out the circuit with normal saline. That's like clinical stuff right there.
Exactly.
What did I tell you?
I did that.
Listen.
I could do clinical stuff.
And you don't ever do clinical stuff.
Right.
So why? Remember, what did I tell you? MBRC Hospital, you have all disposable equipment. So why are you taking a disposable piece of equipment and reusing it? MBRC is saying disposable equipment, you dispose it. If it gets what? Soiled, dirty, contaminated, all those type of things, either showing you or telling you, you get rid of that junk and grab a new one. There's no cost involved here. You're not looking at what it costs to get a circuit, right? Okay, so that's why I think that's why I do the tests later, because these are test-taking skills more than knowledge. I truly want to believe that. Put in the work, it's going to be test-taking skills. All right. 65-year-old female patient, distended jugular veins. I just want to stop there. What should you be thinking already? Fluid overload, right?
Yes.
Indicate fluid overload right away. Dehydrated, that means not enough fluid. Emphysema, how do we deal with that? How do we do that again? The PFTs. See what I'm saying? And look, no one's selected, but it's hypertensive. What is that telling you?
High blood pressure.
Okay, how do you know that? You're just going off the fluid?
Right, no, exactly. How would
There's
that-
nothing given. But what is given is, you know, they're fluid overloaded. That's a sign, clear cut. Clear cut. Okay? See what I'm saying? This one? Yeah, I get you. Make it simple. This is entry level right here. We need a lot more stuff to get. They're not really going to go diving hardcore on you like that. Don't try to say that they're tricking you. Keep it simplistic. Keep it simple. I know it's easier said than done, but think about it. There's got to be more information. When you say hypertensive, you've got to have some type of basis. How do you know that that patient's in there? Give you no values. Told you nothing about that. But they did tell you there's a lot of fluid and there's edema, right? So I always told you that. Okay. Here's the one that really kind of like, we need to clarify, because this is even across the board. Listen, initially, the first thing you do is auscultate. Always. Always. Then you go, what? Then you go right here. Okay, capnography, exhale CO2. This is not the color changing one. This is the one that you're monitoring ventilation. It doesn't say purple is orange, gold is gray. No. Okay, but besides the point, that's the second level. So we got to clarify that. First thing, to see placement, auscultation. Why? Because that will tell you if it's right, because you will see a color change on CO2, right? So auscultation is the first initial, because you can hear absent on the left, present on the right. Oh shoot, but you will get color change if this was a color, a caloric one, like a color change one, right? You will see this one change. But what is stat? Why I've never, and this is where I'm getting at. Stat and stat. What does stat mean?
Right now.
Why are you doing that right now? Right now, like stat, that's an emergency. They're crashing. We need to know what's going on. Stat, that's when you select stat. Stat is like, running over there. No, chest x-rays are done within what? And then you gotta do you gotta do an ABG within an hour to see the changes. Remember, there's anatomical changes that need to happen a little bit before you just go right in there. Nothing's gonna tell you need a stat ABG, because what do they say, 30 minutes to an hour? That's not stat, guys. So no one picked that, great. But stat chest x-ray, same thing. Only in a what? Emergent flail chest, something like that, you need an x-ray. Okay? You guys are already seeing what's going on, right? You already see a lot of this is test taking. Okay? And that's why we go over these tests over and over, because you guys will see and hopefully put in the work. Because obviously, I heard a great thing, and I'm going to share it to you. I heard, you know what the definition of luck is when someone gets lucky? I heard someone put this together, and I thought this was amazing. It's when luck is when opportunity and preparation come together. You prepared yourself so great that when the opportunity presented, the half-court shot went in. You think that's the first time, and I use sports analogy, and you guys don't know, sorry, I'll try to put it a different way, but if you prepared yourself in this over and over, and then you put yourself in these lights every time, and then that came up and you got a test and it all fell into place, you're like, yeah, I got lucky. No, you didn't. Preparation and opportunity came together at the right time. Luck just doesn't happen unless you know, that's like lottery, right? Those are luck. But what we're saying is when they're talking about this type of stuff, opportunity and preparation. When they come together, that's when you can put it together. So there's going to be a lot of that luck on this one. Prepare yourself. When the opportunity comes, you can figure out the answer. And a lot of that is all this right here. And that's why we put these in here, because these are the words that you're going to see. Those are all test-taking skills, guys. That's all it is. Okay? All right. So here you go. This one, 86. Difficulty and reclining. Okay, someone had a problem with reclining. I can't really help you if you don't know reclining like a recliner. It goes back and a reclining. It's not lying flat. It's not laying down, right? But like a recliner chair, right? So, but anyways, the term used to describe difficult breathing in a reclining position, right? Okay, this is it. What's this? What's this? What's this?
Standing forward. I don't know.
An upright? Yeah. And what is this? Declining. Right? Okay. That's just knowing terms right there. Okay. This one right here. Okay. What is fetid?
Foul.
Foul. Right. There you go. Mucoid? Mucus clear, white, like, just like thin, just mucus, right? But pertinent is where you get to the colors where you go yellow to green, right? Why is it yellow and green? Think about it. Is that how, when you get something pus and it gets infected? Pus, let's think about it. It's right here.
Your video came in handy with that.
Did it? Cool. See? And it's tenacious. What is tenacious mean? Thick. Great. Perfect. Okay? This one, I think somebody just really missed the ball. This one, I don't know why, but. Homeostasis, guys. What is homeostasis?
Hemostasis. Damn.
No, it's a balance. Perfect state. They're in great standing. When the patient's in homeostasis, they're level, they're stable. Everything is
That's what I'm saying.
good. When you say homeostasis, no changes, everything's good in the patient, no changes. They're great. Hemoptysis, that is where you see the bloodstream. Sputum. All right, so what's this one?
Isn't that hemostasis?
Sputum?
No.
It was
Didn't that say
hemostasis.
hemostasis, not homeostasis?
I don't know. If it was, I
That's
just,
like-
even if we don't know what that is, we need to know what homeostasis is. But it's a good call out, Dean. I was off track. All right, patient was intubated during successful chest radiograph was taken. Is important as what? Okay.
Easy.
And so why didn't somebody? Oh my goodness. That's my answer.
That's tough.
Who skipped that one? That should have been 100, guys. That's obvious, right? I feel bad for that person. Okay, so this one, guys. This is the one you got to know. Pedal edema, congestive. That's why I hate acronyms, guys. CHF. Probably you guys probably stuck with that, and it didn't help you. Because if you say it in your head, don't say CHF. Say congestive heart failure. This is one of those ones. Whenever you do acronyms, it kills you on test taking, especially in respiratory, because it says it in the name. Chronic obstructive. Chronic and obstructive. But if I learn COPD, I kind of could let my brain miss that, right? But if I constantly tell myself, then you know. Kidney's the next one, right? Because we know that's non-cardiogenic pulmonary edema. But cardiogenic pulmonary edema is CHF, and we are RTs, guys. This is what we're gonna look at.
Okay, I have a question on that one.
Yes.
So it's pedal edema because it's heart failure, so there's fluid overload.
Just like the other question, whenever you see pedal edema, doesn't matter where it's at, you just focus on the edema. Means fluid overload. Then you take fluid overload and you associate for the most common CHF.
Okay.
Does
I was
that make
thinking
sense?
kidney because we're talking about the electrolytes and stuff, and like the kidney failure, and I was thinking like it's gonna retain more of that electrolytes and
I get you, but if it
That's-
says
that's
nothing,
not-
the most common, so that's where we
Okay.
solidify it now.
Edema.
Moving forward,
okay.
most common, congestive heart failure.
Okay.
Which is what? Fluid overload, JVD, jugular vein distension, pedal edema, all these things, fluid overload. Most common, what is it? Alright, so here you go. This one, tachypnea, right? And this is just going over it. We know what? This for sure you got to take out. Yes, yes, yes. This one, what happens to your respiratory?
Because it goes down, yeah.
So that's when you need to look and you see 3, it'd only be 1 and 4, but you'd have to take this one out and this one out. But you see what happened? 8 and 8, only 2% did that. So that's why you need to focus on that. That's why I call these out, and that's why I want to do a test like this. Because really, narcotic overdose, okay? The only thing that you need to know about that, except for the medication you give, is how to treat that patient. If I'm looking at that patient and they are drug overdose, do I look like they have a disease? Do I treat them as a disease patient?
No.
They treat them as a normal patient. It's the drug that suppressed their respiratory rate. It's nothing anatomical or physiological that's in their body. They don't have constrictions. They don't have COPD. They don't have ARDS. They took a drug. It made them go apneic or suppress the respiratory rate. So we give charcoal, Narcan, all these things, and as soon as they come back, extubate those patients right away. You don't need to go through the whole CPAP, SRV, not with normal. That's on when we get to mechanical intubation and ventilation. We're going to get to that. And I'm going to strongly tell you, if it's a normal patient or a drug overdose, you treat them the same. Extubate right away. Why? Because they're normal. They don't need the long-term effects of getting oxygenation, COPD, and all that. They're used to breathing normal. They never have limitations outside of what the drug caused.
They can protect their area.
Protect their airway. That's all you're doing, right? Okay? All right. All right. Which of the following may cause a trachea shift to the right? Here's where you got to think about it, okay? Right-sided tension pneumothorax. Which way would it shift? Right-sided large pleural effusion. It's going to be odd. It's large. So far, it's had pushed it away. Left lower lobe pneumonia. Okay? So it says it's to the left, right? It's going to be there. So right upper atelectasis. And that's,
Does it matter where it says like upper? I think there's another question where it said like upper or lower lobe.
not at this point, no. When they do this in the MBRC, they're just going to ask you if the trachea shifts, and it'll be all in chest X-ray interpretation. So you'll just need to know what's going on.
So with atelectasis, it's going towards the affected side. With pneumo, it's going away from the affected side.
That's it. Perfect.
So like if it was a small pleural effusion,
It could be. It could. That's the thing. It could. But as it gets large, it starts to push everything out of the way because the lung gets restricted. Remember, the lung kind of goes inside the sac and gets real small, and all that fluid is in there, so now it can't expand. Right? That's right. All right, so here you go. It's all correlating now. It should. This is the same question I've seen 3 times, but just presented in different ways. Right-sided heart failure, what do we talk about that? Cor pulmonale, stuff like that, right? It's cardiogenic. Okay. All right. What disease is barrel-chested? Heart failure? Someone put that. This is where I get a little concerned, as you should if you put that, right? Because this is straight up barrel-chested is COPD. You see how they gave you a sign? How you said, oh, but that's not an all, end all. They just made it like, you see barrel-chested and they gave you 3. See what they did? Heart failure, pneumonia, pleural effusions. Right? And emphysema. That's all COPD went out of all of those. So yeah, it's not a diagnostic tool. You don't go, hey, you're barrel-chested. I don't know if you're barrel-chested or you were born that way. Right? So if they're telling you they're barrel-chested, so that's why I'll say it's COPD. All right. While examining the patient, respiratory therapist noticed the patient has what? Diminished breath sounds. Right lower lobe in the basis. Another catch. And the trachea has shifted to the right. These are signs of. See, and left-sided with what? Away. And you see majority with 69, 25%. I think we're all catching this. It wasn't the level of the test and the questions that were presented, it was how you approach the questions and how you look at the questions. Right? You gotta find a way to make those associations. You see how the content is now carried to now, you gotta build something? You see what I'm saying? You gotta actually make associations. I'm giving you Lego pieces, and I'm asking you to build a house. You see what I mean? And that's where it's gotta come from. You gotta find out how you can start association. Because a lot of these questions, and on TMCs, I'll teach you a trick later on, but you can not know an answer, and then 10 questions later, it will give you the answer because of the way they put the question. You know what I mean? Then you can come back, like all three of these questions are very similar, just changed up in wordings, right? But you can actually figure something out later on the test and make changes or find the answer. Okay? So look at this one. Okay? This one was all over the place, but look at this. What is this? What type of breathing pattern? How many legitimately watched the video?
I fell asleep when I watched it.
I fall asleep too. So. I'm gonna tell you, I hope the people that watched it got it right because it's that important. I put that one on there, guys, and it's almost exactly what it says. Increase, then decrease. It's almost like a fire, and then periods of apnea. Fire. That's how I look at it, like a fire. It kind of jig-jags up, jig-jags down. See how it says? That's how I interpret it. Rate first increases, then it decreases. Then it's followed by periods of apnea. And that is Shane Stokes, which we need to associate that with CHF. But the other disorder could be what? Central nervous system. Remember, if you have periods of apnea at any time, guys, you can always put nerve in there. Think about that. Why are you having apnea? Because it's not, the signal's not connecting. See how you know to connect these? Like, even if they throw that one in there, you can't ever take central nervous system if you're not breathing. Because that signal, how are you messaging to your lungs, right? Or you like to breathe. The respiratory center drive, right? Your pons always send it out. But if there's something that's not happening, we know that could obviously. So if you have, wherever you see that, periods of apnea, you can always throw that in there. But we are going to associate that with CHF, but that's always thrown in there. That's just a test-taking question on this one. So you'll see next time you go better. Metabolic acidosis, that would be Kussmaul's, DKA. If you didn't know it, well, 20% didn't, thought that was different. And Kussmaul's is what? Rapid deep. That's what you need. Because if you see rapid shallow, that's just tachypnesis, rapid shallow breathing, right? That's like that. But no, these guys are rapid, like, and deep with contractions.
It's also wonderful.
Yeah. See, what did I say? In almost all TMCs, 160 questions, they're going to be repetitive questions. Not the same question, but on the same topic with the same intentions. Just talk to you different. That's why you see these. They just what they did is just talk to you different, but they're telling you the same thing. This is 3 different people trying to explain a different thing to you, and you just got to know the key words. That's what we're doing. We got to catch it. Okay. On this one, you know 3 is eliminated. What gave you the answer? Do you see that? Like I just realized that right now. You take out 3 because you know. Clear cut, anytime metabolic acidosis, that's DKA. Why don't I like DKA? Because I forgot about diabetic ketoacidosis. See what I'm saying? So listen, guys. Don't do the acronyms on that. Diabetic ketoacidosis, that's metabolic acidosis, guys. That'll put your pHs at what levels? 6.95 to 7.0, 7.10. Critical levels, and these patients will walk out, right? DKA patients. I'm not talking about this patient. This patient will have a hard time walking to the bathroom and coming back. Struggling, pink frothy secretions, all the stuff, CHF, fluid overload, all those things. Okay? You see how 20% still, well, 14, 27, and 20, just because 3 didn't catch them. Right? You see that? 39, I think that question, if we did it again, would have been way different. Because of a DKA right there. You've got to associate that. Right? Because that took away all the other questions. You're only left with 1. All right, 58-year-old female has arrived to the ED with extremely deep and fast. associated with orally intubated in ICU. You asked to confirm the two. It's correct. Upon auscultation, they're absent on the left side. Which of the most is caught? Guys, you always withdraw. Don't even worry about the whatever they're saying. It's a withdrawal. Why is it a withdrawal?
You're not gonna hear it.
So that's what I'm saying. Obtain a stat X-ray. Well, no. Anytime you hear on right and you don't hear on left, you're doing right instant. Don't let it trick you. It's always right instant. Anatomical, the level lock and the level like that. So when it goes, it'll go more into the right. You know, right? Because of the angle. So this one's an angle question. They just put in a bunch of, I told you, this is how they're going to ask you. Not the way that I said, hey, it's in the right vein, so we'll either hold or draw. No, they're giving it to you like this now, guys. This is your TNC. This is a straight TNC question. Straight up. This was a TNC question that fell in the category. That's where this came from. So, looking at that, you always withdraw. X-rays when something's on a decline. Remember we did that? When do you obtain? When you see that something's going south, sudden onset of dyspnea, all these things, you would order an X-ray. Why an X-ray over this? Because you always got to follow in the order of this too. Think about this. Whenever you're treating, you always go for, okay, and I'm going to give you the cat out of the bag right now. Level 1, level 2, level 3. Those are your assessment levels. The first level, okay? Just walking in the room. Think about this. Victor's my patient. I walk in the room, I'm looking at Victor. What am I doing when I'm looking at Victor?
Assessing.
The way he looks, the color. Because I've been in there earlier. I've seen him. I can see where he's going. Color looks good. He's breathing. I'm looking at chest rise. Looking at all that. Well, I don't know about all that, but you know, I'm looking at stuff. I'm looking at him, right? And I see that he's looking great. He's looking at the TV. Whatever he's doing, he looks like he's going. He's on the phone. He's talking. Looks like he's pretty stable. Just observation, right? All these things. Look up. But you're doing nothing of what? Touching. Level 1. So think about all the stuff you can do without touching. It's that easy. Without touching your patient. It's a look, color, diaphoretic. Can I see if you're sweating? Yes, you can. Accessory muscles. Well, you know, you can look, but you're more going to need to feel because you're going to have a gown on, right? But yeah, you can see if they're, the scalings are going up like this and stuff. Yes. Tripoding, those things, personal breathing, right? Okay. Level 1. What's level 2? Auscultation, pulse ox. I'm touching the patient now, right? I'm touching the patient, so think about that. Now level 3 are the most extremes. You only do those in emergency or when you need to. That's why you would never put this. Do you think radiograph where you just got one every day would be harmful to your patient?
Yeah.
Yeah, you have to wear a little thing how many times you're exposed. That's level 3. That's ABGs, CT scans, MRI, all those things. Level 3s. You will not select those because those are endangering the patient unless it's like you absolutely need the best answer. Does that make sense? When you absolutely need the best. But if it's a rapid, do you select the level 3? What's the most rapid? Look, I got an instant feedback right now. You look pretty good. You're breathing. That's instant. And then second level, right? But if you want the most accurate, do you do a pulse ox? That's level 2. You do that above an ABG. But if I needed to know for sure, you do an ABG. Does that make sense? Level 1, don't touch. Level 2, touch. Level 3, inside. Photograph, inside. Think about it like that. That's how I did it. That's how I associated it. Stay with me forever. My assessment, if you guys haven't figured it out, I'll tell you over and over, got to get the assessment down because all of it else will fall inside. Got to get your assessment skills down. And that is doing all the stuff we're doing. That's all test taking. It's all observing, observations, looking. Level 1, look. Level 2, touch. Level 3, inside, invasive. intubations, chest x-rays, those type of things, ABGs, bronchoscopies, you name it, right? Okay? So, anytime, right main stem intubation, withdrawal. Don't worry about how much it's saying. If they give you something, then maybe you gotta stay within that level, but they don't tell you anything, so I'm just gonna go with withdrawal. You know you're not advancing, you're not gonna re-intubate because you're already intubated, you're in the airway. You only do that if what? You get poor, which is purple, on the color changer. That means, or you see a capnography, which you get later, and it's reading 0. Because there's 0 CO2 in your stomach. So don't let them trick you. You intubated and you got 0 reading on capnography. That means because you're esophageal intubation, guys. You're in the stomach.
If you drink soda and
But let's just keep it simple. But no, yeah, so you will get 0 readings, and that's an automatic, it's almost like the right main stem intubation, you withdraw every time. And when you see 0 on a CO2 intubation, it's always, you gotta intubate, because you're in the stomach, whatever that leads you to.
I was gonna ask with the innovation question, when it comes to the TMC, are they ever gonna give us like values of like where it's like at the teeth, so we would know
Oh,
how
for
much
sure.
to draw
Yep.
back and
And we'll
everything
get
like
into
that?
that. You're always gonna be, and it's like, they'll say 28 at the lip line. What should you do?
Withdraw,
Get that in
but
there.
I was just wondering like, cause you were saying like, don't worry about the numbers unless you absolutely have to. So that's why I was asking.
That's when they would give it to you, but that's not on this one, on
Yeah.
this question, but yeah, when we do mechanical ventilation, we'll get into that. For sure, but yeah, good call. Alright? So, not an x-ray unless you need to know exactly. Now this one, guys, what was this one? 99. Okay, this was just straight off of that. Okay, this one's pretty going over, but look. Now, here's the part that where you see this, okay? When do you get 99? When it's decreased on the lower right side.
Air.
Atelectasis on the right. Is it more air or less air?
That's consolidation.
Less, okay? So it threw you off with pneumothorax, can I go with that? But why did that throw you off when it's right-sided? What happens anatomically when you have right-sided pneumothorax?
There's more air on the right side. Cause it's not tension.
The distance between.
Yeah, see, there's the key, did you see that? So what happens? There's no?
Oh, it doesn't bounce off as much.
The vibrations are not that,
They're dull.
They don't, that's exactly right. So look at the atelectasis on the right. Is that gonna be dull?
It's gonna be flat.
Less air.
That's what atelectasis is. It doesn't say that it's filled up with anything.
Yes.
Atelectic is not edema. It's not anything at this point. It's not pneumonia yet. It causes that. What is atelectic lung?
It's just a
Collapse of the alveoli. Just collapse, right? So that's the main thing you gotta look on. The pleural effusion. That's in the pleural space, right? That's where you have fluid in the pleural space. What is the pleural space? It's a sac that encloses your lung. So your lung is now being encapsulated by fluid that's surrounding it, right? So you look at the next one. Pneumothorax, we just talked about, it's not a tension, so we don't figure we're gonna have any shift. So the atelectic lung, you gotta know, no fluid, just know the simple about it. It closes off and it can't come out, so that whole thing closes down. And so what is our treatment for atelectic lung? Hyperinflation therapy, right? And we also call that what? Right? And then we also call that lung expansion therapy or lung recruitment therapy, right? Because we're recruiting, and you can actually recruit more alveoli from that, okay? So this one was a tough one. This is a tough one. All right, I'm palpating the neck region of the patient on mechanical ventilator. Cracking sound, sensation. That's what you needed, right there, that was the key. The crackles, remember? Rice Krispies, crackling, air pockets in the derma, subcutaneous emphysema. You won't hear crackling, you're gonna hear what? Rales, course, bronchi, those are gonna be the terms you use for the lungs. You see, when have you heard crackling in the lungs, right? No. It's gonna be what? Coarse, fine, right? That's what you're gonna see, right? It's gonna have association with that. But not sub-Q. This is crackling on sensation. What is sensation?
Nothing to do.
That's right, touch.
Yeah, and
That's what that is. It's a sensory. Alright, when percussing a patient's chest wall, you encounter the area produces more resonance with percussion.
like,
So what does more resonance mean on percussion?
Decrease.
Decrease, that's what I'm saying. What is more resonance?
yeah.
Hyper, low is decrease, which is hyper, which is less air. So think about that. That's where I'm trying to go with this. More air, less air. Okay? Which of the following, so pneumo, right away, out. Going down. See what I'm saying?
Is he the only one?
That's the only one. What are the two
He's the
that are
only
going
one?
to cause more air?
No, it's like a
COPD and pneumo.
4, 3, 4.
So we're looking at, right?
It's just one.
Oh, that's
Alright?
Like a cringe.
really.
We have, while percussive chest wall, you detect abnormal increase in resonance. Now we're looking at it a little bit different. And think about that. Look, asthma, pneumo, and what did I just tell you? COPD and so can I say that right here? Asthma, emphysema, are those COPD? Yes, they are. And the main point of that is increased air, guys. And we know, or we should know, that pneumonia, you don't pick that. That's not increased air. It's increased consolidation. What does the presence of stridor mean? Guys, it's upper airway to the finest. We don't know. Could be causes, right? But we know for sure it's upper airway.
I almost put the secretion one, I just thought about it.
We gotta add to that, right? You don't wanna just know the root of it, it's upper airway. Okay? Alright, this one looks good, the opening of smaller airways, this one, no, this one's an expiration cause adventitious. What is that? Adventitious sounds.
Oh.
But you saw coarse crackles, I think that helps you, right? Coarse crackles? Yep, clear sounds.
Anything other than.
So this one definitely, guys, you know that's not variable obstruction to flow, opening of cloud, like a lot of this stuff, right? But you know for sure the movement of excessive, because you can hear it, coarse on what? Throughout, both inspiration and expiration. And then all of a sudden, they're clear when the patient coughs. They move, they're gone. Alright, and this one, guys, is just, I can't explain to you. You're gonna see this one. If it's creaking, grating, rubbing, something like that, it is friction rub, which is pleurisy. And remember, that's where that is just rubbing skin to skin. We talked about that.
I was heard as a leather.
Yeah.
But,
And that's what the MBRC hands out. They love grating. Grating is like grating cheese. You're just rubbing on. That's a grating.
Similar to coarse crackles, that sounds awful.
And it's very painful. So you'll get simulated where the patient is wincing or having pain on inspiration, expiration. Well, that's pleurisy. That's this right here, the friction rub. That could all be included in there. So they would need to be sedated and mechanically ventilated. So rails is just another thing for what you're talking about. Like rails, fine rails, coarse rails. They just use now it's all crackles. Crackles was rails was an interchangeable name, like an old school term, and it kind of eliminated rails and just got rid of rails.
Can you take a picture of it?
Alright, so this one, we kinda know, right? Apple or bait, 8 is
Great.
great. Thank
Great
you.
baby.
Okay, this one right here, all the volume practitioners should, look,
Societies. What's societies though again?
Yeah, that's what I wanna know, what is that?
that's right, it's more for your alcoholism when you have liver.
Oh, yeah.
Right? When you, and you'll see ascites will come up with a yellowish color called jaundice. All of it is going to be associated with your liver patients, guys. So you definitely are not going to look at extremities where the liver is not on the wrist. So ascites, just knowing where it comes from. Alright, so this one, COPD, ER, shortness of breath, bilateral, coarse crackles, lung fills, puddle edema. You see what they're going with it? Bilateral, fluffy infiltrates, bat wing. And people picked outside of it, guys.
Anything else kind of like?
And so what is that? That's gonna be, what would you say that would be if we gave a disease pathology there? Very good, why would you say that?
That's why I was looking at
That's what I was looking for too.
But that's why it's a test taking. We'll get you to the.
Yeah.
That's
I thought about the crackles, I thought about the payroll edema, and I was
The
like,
elephant
okay,
too.
that's what I said.
Very good, because this is where I need to tell you guys, this is where you would take it before and we'd say, okay, pulmonary edema is your answer. That's not what the WRC is gonna do. This is a perfect example of that. They're giving you pulmonary edema, but they're not giving you that for an answer. So you gotta work it out to know what that means in a different way. That's left heart failure, okay? All right, which is non-cardiogenic. Yeah, see? You got that? An RT is examining a patient suspected to have left-sided tension pneumothorax. During that, right? Look at this. Inspection, palpation is touch, right? And then RT notices the trachea has shifted to the left. Is this patient diagnosed correct?
No.
What would you do?
New one would be to the opposite direction.
See this one? This one gets me. This is a bearing. This is probably like the easiest besides minute ventilation. It's like the easiest calculation ever.
I was like,
One times 30, and then a half, so 15.
What's half of 30? What's half of 30?
Yeah, 15.
They'll never give you that. They'll never give you 20 cigarettes and 10 cigarettes. So Danielle goes off of how many cigarettes. It's a great way to remember. But really, it's not about how many cigarettes in a pack. They're either going to give you pack or a pack and a half. So you know that's 1.5.
Yeah.
It's the only difference. So yes, I don't know, 20, is that what you said, 20? I don't even remember that anymore. I was a previous smoker, so I should know that. I was in respiratory school when I started smoking. It's crazy. Back in the day, we were all outside smoking because we were so stressed out. And then we were like, hey, you guys are RTs smoking? We're like, yeah, job security. And we thought that was funny until started coughing up lungs, and reality started being. I went in there and I went against this Chinese guy. He was from Burma. If you guys know Burma, it's like a very hostile place. So I love to hear stories from this guy. We'd sit in his park. The guy was like 80 years old. I'm like, nowhere close to that at this time. And he was outperforming on PFTs because I was smoking. It was crazy. I was like, dang, man, this guy's got, crazy lungs. And like, you're supposed to be on the decline on that, and I couldn't beat him. And after that, well, kids was a major factor, but I quit after that, just to say. definitely not something to carry on. So. All right, 23. Planning of what? Oxygen, protocol, symptoms, tightness. 28, loose productive. Right? Bilateral wheezing.
Wheezy.
You always got to go with that, guys.
tightness from the.
Don't, you know, the chest tightness is a good key for that. Chest tightness is always an indicator for asthma, guys. Alright. Here we go, 65-year-old patient. This one, you guys got majority. So you guys got this. See how majority of these questions are all following, just asking in different ways?
Yeah.
Yeah?
Air travelers.
Okay, this one looks like everybody got it. Why even go with that? That was great. Okay, this one is very important, guys. Red blood cell above normal values, polycythemia. And I also gotta tell you, this is associated with COPD. COPD. Remember, they go from a what? A ventilatory drive, what? CO2 driven, as we all are here, right? We got it? And then we go to an oxygen drive, right? Remember, it's now their oxygen levels got to such levels that they are now needing that for life. So now they're dependent on oxygen, not CO2. That's why you have high CO2s and high compensation, right? But how they combat that is they produce more red blood cells and get more buses. I always call hemoglobin buses, guys, because I look at it as troops. If you guys haven't heard that, that's a military thing, right? I'm looking at how we get to these battlefields. That's infections. White blood versus an infection, or whatever. But we're talking about hemoglobin. So we need to unload oxygen to support the muscle, right? So that's like bringing supplies to the front lines. If you don't bring supplies to your troops, they have no water and food, they start to die, right? So COPD is having a hard time with that. So what they do is they produce more red blood cells. And this is also seen in sports analogy. Boxers, people that need duration or length to stay going, where do you think they go? Big Bear to train, high altitude. Why do they go high altitude? Because the pressure, it's not the amount of FiO2, that's not the tip, it's the pressure. So the pressure, it's negative pressure, right? And we get driven in. If the pressures are lighter, so it's harder, that's why it feels like a struggle to get air, because it's not so easy to get the air in, because it's lighter. So why you see that is because athletes and trainers that do duration type stuff, boxing, MMAs, stuff like that, high altitude, run up there, train up there in the mountains. When you come back down to sea level, it turns, they're going for this right here, polycythemia, guys. That's what they're doing. That's sports science right there. Increase your red blood count. So why do you think doping and Lance Armstrong? EPO. EPO is a hemoglobin producing red blood cell drug. You give that, it automatically just replenish all the red blood cells. That's the Lance Armstrongs, guys. That's an duration sport, right? Riding a bicycle for hundreds of miles and feeling great the next day. That's the doping that happened. It wasn't like some super drug. It was red blood cells. That's all it is. It's a science. Okay? So again, main point, and I'll answer questions. Polycythemia, back on track. COPD. Okay, I like that you associate polycythemia, knowing that it's a above normal count, and who's going to be associated. Because you'll see a patient comes in struggling, have this patient. Now that is a good indicator when they put polycythemia in there. That if you see a COPD as one of your questions, or emphysema, or obstructive disorder in there, that might be where you choose that, because they represent this category. Questions now.
Leukocytosis, that's for white blood cells?
Yes, it is.
Elevated.
And leukopenia.
And that's lower.
Yep.
Okay. See,
White.
Huh?
White blood cells. This is
white.
red.
They say white.
These are RBCs, not WBCs. See what I'm saying? That's
Anemia would be low red blood cells.
Anemia is the opposite. Those are just opposites. It's the same thing. This one right here, this one right here is just different, but this is RBC and that's WBC. This one here and this one here are the same thing, but red blood, white blood. That's all it was. Deegan.
So a COPDer who has like a GI leak, let's say, they're going to be in really bad shape. Okay.
Really bad.
Give me that blood. 3.
Yeah, that's why when you see that brown emesis, that coffee ground, that smelling coming out, COPD air, that's old blood, that's brown. That's where you see the coffee filters, you know, you pour it in coffee, it does nothing. They're like, well, it helps a little bit. I've never smelled coffee when I walk in those rooms. It just stinks. GIs are the worst codes, guys. If you haven't been in a GI code, it's just gross. It comes out like eyes, ears.
Oh yeah, I actually seen
And it's brown. And that's where we're, it's old blood. That's what we know, okay? We're good? Can we move on? Yes? What is the test? This is it. For clotting. Okay, let's go through. Red blood count is the whole over encompassing all red blood, right? Okay. Neutrophil count, that is for white blood. Okay, that's what they're calling hematocrit.
Oh, changed it.
You change it
I
all.
changed.
It's platelet. Remember, your platelets, think about stacking, I think about plates.
Yeah.
So when you're trying to clot, you're trying to thicken. So I just think of the plates.
I think I changed.
PLALETE.
All right, and this one?
Yeah.
Come on, how did someone miss this? I think this one you're taking to go over so much. Right, so what's the 10%? What is that one, guys? And if you pick this one, what was this?
Sodium.
Sodium. And it's 135 to 145. I made it so we can easier remember. So we pick sodium when we need to know potassium. Guys.
Plate. No,
Okay.
PLAT. Yeah.
Okay. Right here. Here, man. After you see what I'm saying? I mean, this is a perfect example. You miss like 5 when you miss 1 because of the concept. Now I know the concept. Right away, I see JVD. I didn't even read too much already. Jugular veins in the neck, distended. What am I thinking about right now, guys? Well, I'm thinking of no. Let's keep it in mind. I told you. What do I think? Fluid overload. See, if you think when you read that you gotta come up with a different answer every time, that's not what we're doing. Stay on track. If you see JVD, what's the first thing that pops in your head? Fluid overload. Keep reading. You see what you do? You see what you did there? And then when you come down, you go, okay, well that's the main thing I need to get out of this, right? And I say, okay, what down here is gonna represent fluid overload? Systolic hypertension, hypovolemia, obstruction of the pulmonary vein, or right ventricular failure. What happens when right ventricle doesn't fire? Causes backflow. Okay? Post-operative adults, right? And let's look at this check say consolidation. I take out anything that's COPD or pneumothorax. Right away. You see what I'm saying? Increased air with those guys. Consolidation, I took that out already. You see what it said?
Wait, so if they didn't have the tracheal shift, it could be this consolidation.
That's what it is.
Sorry, I meant out. Like, if they took out the no shift trachea.
That's exactly it. There was no shift. So when do you have a shift? Test taken. That's all that was. Okay, bilateral bronchi, both sides, bilat, right? Okay. Determine effectiveness of the cough. How do you do that? Forced vital capacity, sputum culture, maximum. You're not doing any tests. Look at what it said. Your auscultation. If you heard it, we've been doing this in the whole thing. Listen, for one thing, we haven't talked about any of those tests from sputum culture. Now it's 8%. I'm not tricking you here, guys. If you haven't heard MEP, that's his test taking strategy 101 for Mr. Cates' test, not even TMC. If I haven't talked about it, I'm not going to put it out there, guys. So if you don't know what forced vital capacity, why'd you pick it? Didn't talk about it yet. I mean, you might learn it others, but I'm not going to auscultation, that's what chapters we're in,
I
right?
think I put sputum culture about.
So if you did that, okay, I can somewhat
I was
relate
thinking
that.
like it's culture sensitivity type of.
But right now, it's very, very simple. Don't look for the MBRC, TMC is gonna look for you to know all these fancy tests. They just need to know when to use them, but as an RT, you're right there. You're auscultating right away, you know. But think about that, to do a forced vital capacity, what are you gonna do to get that if you select the 25? When you're examining a patient's chest, what should a respiratory therapist perform the patient cough to determine effectiveness of the cough? Have you heard of a forced vital capacity for cough? What have you heard that for? It's a maneuver for. See what I'm saying? You guys don't even know really what it's for. But it is a spirometry, or it's what? It's to see how much you can get out, right? If you talk about a vital capacity, the capacity is 2 or more volumes, right? In spirometry, we'll get through that. But we'll look at it. So I'm gonna say, I think VC is everything except for RV. I might be wrong, but I think it's that. So think of it, expiratory, expiratory volumes, right? It's the vital capacity. It's how much you bring in, how much you exhale. So you're not doing that. You're not doing this bedside spirometry. You're not going, put them in the body box to see if they have effective cough. Think about all the stuff you're doing to do that, right? Sputum culture, but the same thing, MEP, same thing again, how are you gonna do that? You need some kind of gauge or something to do that, right? Okay. All right, following successful reintubation, so you know it was good, successful, right? And the examination of patient, what should you recommend? Trach tube? No? Everybody got it? Immediate extubation? Breathing treatment? No, okay? Successful, okay? It tells you. See how that's when you pick that? Because it's only best answer. Okay, here we go. Ooh, is that elevated?
Yes.
It is, right? 15s are cut off. 11? What is it? 10? I like 5 to 10, but 11's the ultimate. But 5 to 10 gets you ballpark, right? But 18 seems a little excessive. Over 17. And look what you see again, air bronchograms. Always, you gotta associate that as pneumonia.
And I thought they also,
The way my mind worked was it is an elevated white blood cells and ammonia is an infection in the lungs. So you're gonna have elevated white blood cells, so none of them have, yeah.
So she's on the, let her finish, she's on the right track, I want her to finish, so what else, keep going.
So if you look at atelectasis, it's not an infection, it's just collapsed alveoli. Pulmonary edema, I mean, that's overload of fluid, and pleural effusion, that's fluid in the lungs. But none of those would really give you a high blood count, because the patient is febrile and pneumonia is an
That's
infection.
your clear signs, I hope you heard that. Temperature and infection. The rest of them are just collapsing or what, there's no infection. It's IS treatment, pop them back open. Pulmonary edema, positive pressure in Lasix. Think about our treatments here, right? Pleural effusion. What do we do for pleural effusions? You need to, you gotta get the fluid out somehow, right? Think about it. And then pneumonia is an actual infection. It's actual pertinent. We can start associating all this stuff with pneumonia. Yellow secretion, that's a sign of infection. Temperature is a sign of infection. Consolidation's the thing that can lead you down there. But pneumonia, they already gave it to you. How else can you see pneumonia if it wasn't written out? What else is the acronym for pneumonia? PNA. You might see it like that, guys. Don't think PNA stands for anything else. It looks a little funky, right? But that's pneumonia, guys. PNA.
They're saying that anything over 17 counts and is considered sepsis.
But severe, pneumonia, sepsis, because now it's there. But if sepsis was, you're 100% severe infection. Very good. Okay, this one right here, always LOC. LOC, guys, you gotta know that. That's, what level would that be? Level 1, 2, or 3? 1. There you go, LOC, right? That's only, that one right there, emotional state, you can feel it whatever type of way. But we gotta see if you're conscious, where are you at, right? Assess, do you know where you are? You know the date, you know where you are? Very easy. Alright, this one here, laryngeal edema, guys. 71 got this one. 2 hours, remember, a patient stridor. And look what it said, a treatment with, and we just covered that today. But what if it said post-extubation with marked stridor? What would your answer be? Not in what's going on, it's still laryngeal edema.
Reintubate.
Where? Huh?
Intubate.
Intubate, you see? But this one right here, this one would have been if it was presented. See how different ways I can spin this question? Right now they're asking you what the problem is. Well, you just know it's edema or constriction, right? And we talked about that. Saline, racemic epinephrine, intubation. And when is the intubation? When it's marked or severe. And that is on epiglottitis, or we see stridors. Remember, there was only 2 things I told you to intubate. Marked severe stridor or epiglottitis after extubation.
What does mark mean?
Marked is severe.
Severe.
Yeah, it's just
Marked
like the
is
name
severe.
Mark.
So when you get
Mark
marked down.
with the ED. Marked stridor. It means like they marked it out. Like here it is. Like I don't know. It's just the term. Okay. So it's noted. You know. All right. This one, guys. Let's see what you guys. Okay. So look at this. You can see the ET tube. You see that? That tells you right here, there's no ventilation. Air is black, dark color. White is no air. So all that telling you is alveoli just collapsed. There's no air pushing in that left side. That is a right-sided. You see that? I mean, I don't even, you can just look at it and look. You know, endotracheal tube, but go back over here, because you will see these guys, like this one right here, you will see this one, okay? And I gotta make sure that you can identify this white line, and this is the tip. You guys all can see that, okay? But look, it even has a curve to it, to the side. And you have to go that deep on it, right? And I can't see any vascular markings. Can I see my aortic knob or arch? Do I see any of that? Can I identify a claustropenic angle? I can see it all clear. If it looks this clear on the right side, it's going to be amazing on the left. You know, the right majority of the time is going to be more jacked than the other side, only because of this. Did you know that if you had this right here, you could actually say, if you have right-sided pneumonia, you're almost secure to say that you have aspiration pneumonia. You see how you can work that out? Not to say that it's 100%, but guess what? If you have right-sided pneumonia, we can also say you have high probability that you have aspirated. Because aspiration pneumonia will be right-sided pneumonia, guys. It won't be bilateral. Bilat tells you it's pneumonias and stuff. They're very rarely on one side or the other. Pneumos are on one side or the other, but you'll see those like TD, they'll spread out. They don't go in. But if you aspirate, you guys all know that, right? It will go into the right side. All that fluid goes in there. And what happens? Turns into an infection. We call those VAPs, right? Ventilator-associated pneumonias. Okay? So this one right here, you guys got to see that. Identify, and you can already see, I can look at it really close here if you really look at it. I want you to look at a lot of these, and this is past the bifurcation by far. Because that's the only next thing I can see, is I can see, there's like, you got to look really close, but you can see there's a point right here. There's a point, okay? Now I'm going to move my fingers, and I'm going to put it right here, and I can see the ET2 ends here. That's the bifurcation. If you look, there is a grayish mark. It's very hard to see, but you can see it, that there's pretty white in this area. Well, all of a sudden it starts to get a little gray right here. You see that? That right there is your carina, your bifurcation. And I can see that tube has already crept into the right. That's just going a little bit further. This is just easily identifiable as right and ASIN. You just see something like this, just pick it. Okay. All right. This one here, C. diff. Okay. Aerosolized, large volume, removal of the room, procedures. Okay. Nebulizer. Okay.
Just because it's reusable, right?
That's right. But you won't see anything like this. The C. diff question, this is a tough question to be in all honesty. The nebulizer question will be home use. It'll be your acetic vinegar solution with air dry. That's how you clean nebulizers. Now, it'll be in the home sit. The glutaraldehyde will be for your bronchoscopy, your bronchoscopes. That's a little key, okay? The next thing, am I not low? I got a plug here, don't worry. All right, the next thing is this, the C. diff. C. diff is the main thing here on infection control. And this one you have to wash your hands with soap and water. The gel in is not the selection on this one. So this is in the stool. So this is a bacteria found in the stool. And so it's gonna be all over, it's contact, right? It's foul smelling the poop and all that, right? And so what happens is, don't think, well, I don't deal with it, I don't even touch it. No, it's on the handrail. It's all over. The nasty, they throw it on the floor in the sheets, and they won't mop it up right away, it's all over. It's on your shoes, there. Just know, when you have that patient posted for contact and they tell you it is C. diff, which is this, that's stool, you cannot kill that with the alcohol in and out gels or whatever that is. It has to be hand washing. You got to soap and water hand wash. Does that make sense? Yep. Okay. Those are the two things they'll ask you with that. All right. And then here's that nebulizer. I told you acetic acid, air dry. White vinegar. Okay. And what's the ultimate? Angiogram.
That's
Yes.
the other two aren't.
That's right. Inconclusive. Very good. Okay. That one, let me plug this in,
What's
guys.
the problem with the system? It's like 40.
Huh? Oh,
I got this.
I don't know what that
it's like that. It's busy.
I don't remember like
I'll look at it.
I think we're like halfway though.
Halfway?
Probably on the next
Or that towards the end.
Almost done.
If your heart's bigger than 50%.
I think like 20 more questions.
If it's less than.
I don't know. I want to eat.
We're almost done, guys. We're gonna have to wrap it. I'm being sorry. I don't want to hold you back, but we're gonna try to get through it. I think I'll have enough time to get through this. Oh, 19% we can get through. We only have a few more. The reason I don't have the plug, I didn't bring it here. It's about to die. So, okay. So you guys got this one?
Yeah.
Okay. So blunting.
Yeah.
All right, that's just the word. I'm just gonna stop there because that one's automatically.
Yeah.
Blunting. You see, these are why test taking key catches. Claustropenic angle is always fluid, right, guys? Okay. And CT. Okay. What is this? Yes, guys. Please do not kill your patient, guys. Please. This is the MRI. If they have a pacemaker and you know that, you're not sending them to the MRI, guys. Please. You stuck up on the machine, like it'll slam you, rip it out of your chest. I mean, I've not seen it, but I heard stories of ventilators getting, once they turn on, it gets slammed in the machine, hitting patients, breaking arms and legs and stuff, guys. Parapack? It's all plastics, that's what you need. Okay, which one? Lateral. That's the only time you ever need to know that. and I put it there. They're not asking MBRC for a lateral. It's only gonna be right here. That's it.
This is
Because what's the most common?
PA.
And
AP.
AP, but the best.
Best is PA.
Yeah, but the most that you will see is AP. Very good. Okay, which of the following are typical causes of? Okay, no, because what's core pulmonale? But what is it though?
Right heart failure.
Yeah, but what is that? What does it do? What is the actual?
Back up.
So how do you treat core pulmonale?
Basic.
And what could happen, like, to infectious, how does this happen? How would you get that? We're talking about the heart, guys. We're not talking about lungs, core pulmonale, it's the
I
heart.
think one of the valves, operating basically because of the back blows
It's
everything.
it's being encapsulated, so infection, fluid, any type of fluid, when you're talking about the heart, not the lungs, not pulmonary edema, that's pulmonary. This is the sac around the heart, right? Pericarditis. Infections, increased fluid. Now the same restrictions that you would get with your lungs and the what? The peripheral sac around, right? Now we're looking at, no, this is the sac that's around the heart. Got the same thing. So now you got an infection that happens, and now it's just holding it tight. It's not gonna do anything. It's not gonna move. It's now, you know, when it wants to expand, the fluid has now hold it like this. So you gotta release that pressure to open it to be able to move with the heart, because now it's holding it closed. So there's nothing happening, not moving, it's serious.
So Lasix antibiotics?
Oh, now your pericarditis, you need to retrieve the fluid, you need to get that out of there. Alright, so,
So what was it's a treat for?
so it just depends on how bad it is, but yeah, infection, whatever's causing it, that's the root. We just need to know how to treat, what's gonna happen. Because yeah, we are cardiopulmonary, but that's a cardiac issue. That's affecting the pulmonary, right? Alright, this is self-explanatory, 8%, look at that.
Why would it have butterfly and bat though?
But that's what I'm saying, what is it?
Bat, bro. I was wondering.
Yeah, and they won't ever do that, they won't ever do that, but just know, where is this, why is this saying? What is it? Peripheral areas of the lungs seen on the chest film, that's where you'll see the hilar regions. It goes up, but the insect, the bat, and all that throws you off. This is a throw off question, you'll never see anything compared to that. It'll be one or the other for sure, okay?
I almost questioned myself and put Hill out in Halo. Because I was like, why?
But what does that mean?
I don't know.
It's the
So
high-
the question.
I'm like, I've never heard of that.
You have it?
It's like
That's in the
upper?
mid, right there in
Oh,
your
okay.
regions, right here is your hilar regions. And that's gonna be on chest X-ray interpretation. And the only time is just the location where it's at. Alright, this one,
Yeah.
we'll put blunting, we know, come on, what, emphysema? Blunting is what? Fluid. We just talked about that. What is this? Flattening of the diaphragm, guys. That's one indication. If you see flattening of both of the diaphragms, COPD. One, pneumo. That's kind of an indicator right there. You have one that's suppressed, right, because of the air, but in COPD, it's not going to judge what side. That's a pneumo. It's going to be both sides. Flattened diaphragm. They're always going to use it for COPD most of the time. Okay. All right. Then we have this one. This one's all except for normal, right?
Yeah.
If they're in respiratory distress, why do they got normal respiratory rate? Okay? Don't do that one. Okay, coagulation study results, right? Right? Okay, that's your clotting. Okay, and this one, 35%. Which of the following infection, what would you do?
This makes
This was
I feel like when you
airborne.
like,
In the clinical setting you do, but like airborne you don't need it's not droplet or contact, so technically you don't need a gown.
Yeah.
And they have to room it.
There's no gown, and this is a TMC question, guys. I know it's I know it's kind of, but you gotta think about this. If you enter a room and it says TV, they already told you what it is. So TV will not get on your shirt